So welcome again, and welcome to this ERKNet webinar. My name is Francesco and I speak from my office in Rome. As always, before starting, I remind you that your microphones are turned off, but that during and after the webinar, you can send your question through the GoToWebinar application that appears on your screen. And I will ask your question at the end of the presentation. The webinar will last approximately 30 minutes. We will then have 15 minutes available for questions, and hopefully by 5 o'clock the webinar will be finished. So our speaker today is Professor Beata Lipska-Ziętkiewicz. I hope that I pronounced well your name, Beata. Beata is the head of the genetic unit at the Clinical University Center in Gdansk in Poland. She has completed her medical degree and her specialty in pediatrics, clinical genetics, alongside with her PhD in the same university, and has now become, since last year, a professor in genetics. During her career, she has performed a number of research scholarship at Paris Descartes University, in Heidelberg, in Geneva, at the University of Nagoya, and at Baylor College of Medicine in Texas. And most of us actually know Beata. She has several interests, most of which are obviously involved in the genetics of different aspects of medicine, and particularly on hereditary kidney disorders, glomerulopathies, and CACUT, in genomic disorders, and in genetics of pediatric cancer. She is involved in numerous collaborative projects, including ERKNet. She serves on the boards of numerous scientific organizations and registries, and I don't have the time now to list them all, but she clearly is a very accomplished researcher and geneticist, and she will talk to us about genetics. So the title of her talk today is Basic Genetic Concept and Clinical Practice. So please, Beata.
Well, thank you very much for this kind invitation, Francesco, and thank you very much, the organizers, for having me here and for having the second part of the course on genetics. The title is the Basic Concepts and Clinical Practice, and as the first thing, I would like to remind you that already 3 years ago, we started talking about genetics, and you can download from our webpage the first part of my talk, when I already discussed some of the basic concepts. And today I will not be repeating myself. I will rather be a little bit referring to that knowledge and going further in the subsequent steps of the ladder that leads us to having a genetic diagnosis in the field of nephrogenetics. So without any further hesitation, let us start. And let us remind where we are with genetics in 2023 here at the ERKNet, at the European Reference Network. So what we have covered in the previous part was the general discussion on genetic variation. What is penetrance? What is variable expressivity with respect to different genetic diseases? The second important topic that I already discussed with you is that there is the new nomenclature referring to variants which can be pathogenic or can be benign. We are not using anymore the word mutation because we don't want our patients to feel as mutants. We prefer to use the variant and then to classify it according to certain classes. So if you need any review of those parts, please go back to the previous talk of mine. We also discussed how to construct pedigree, how to analyze family history, what are the different modes of inheritance, and again, I will not be repeating. Today, I would like to start with those with the step number 3. So what kind of tools we have currently available to do a genetic diagnosis in our patients, what we should know, which one should be used in which setting, and it should be both guided by the money, but most of all by the relevance to our patient, whether this or that particular tool will be useful. But before discussing you the particularities of different molecular techniques that we are using in everyday diagnostics, let me just remind you that in the meantime we have produced as the Molecular Diagnostic Task Force for the ERKNet, led by Nina Knowles, but with all those renewed colleagues of mine who are members of the who are still members of Molecular Diagnostic Task Force, we prepared a statement for the European colleagues who are questioning or who are asking what is the place, what is the role of genetic testing in the diagnostics of chronic kidney disease. And this paper is available as an open source and NDT, and I do recommend that you download it, you read it, you have it at your hand in daily clinic and also when preparing for the final exams in the curriculum. This was a joint project with ERA, so we are really pleased to have both pediatric and adult nephrologists and geneticists working in the field. And actually showing this slide, I could stop because all what is necessary is discussed there very much in detail. But I will rather use the remaining time of our webinar just to illustrate some of the key points presented in this paper. But really, definitely, this is the must-have of anyone who's interested in genetic testing in nephrogenetics. In brief, that was one of the closing slides of my previous talk. I presented to you that genetic counseling is a complex process, that we just go step by step and we first do the medical job. So we just identify who should be tested, and a little bit on that we discussed previously, and we are discussing during all different webinars when to think about any rare disease. But then you start to work with the patient just to identify whether the patient, being your partner, whether he she is willing to have the diagnosis, and what are the different obstacles you may face before you get eventually the diagnosis. So please remember that genetic counseling is not just clicking a test in your computer and having a nurse to take some blood from your patient. It's a lot of thinking, it's a lot of talking, it's a lot of discussion and presenting pros and contras before you get the test and before you bring the test back to your patient. Because genetic testing is not only for diagnosis. What we can do also is to provide tests for family members, this predictive test. So in a moment when the patient is yet asymptomatic, and we can say who of the family members is at risk of having the same genetic condition as our patient. And we can also discuss whether there is a risk for subsequent pregnancies, siblings, maybe other cousins who are already pregnant, so we can assess the reproductive risk as at the genetic compartment, and of course we can also manage those pregnancies in the families at risk, both with prenatal and pre-implantation testing, depending on your country insurance. But definitely, geneticists are there for you to handle, we say, the family. You deal with the patient who is sick, who has the kidney sick, and we take care of her family. What is important, the predictive testing, depending from country to country, and here I do recommend that you go back to your geneticists in your department, in your hospital. You discuss with them what are the frames, the legal frames for doing this. Generally, we in Europe, we investigate that predictive testing can be performed only when there is medical benefit. So when we have some treatment to offer, when we can, for instance, start RAS inhibitors or other treatment to stop or to slow down the disease. And in kidney, what is very particular, it's also the question of live donor qualification. I give here example of young adults from the families with ADPKD, but this is just one of the examples when we can think about testing presumably asymptomatic member of the family before we decide we give the green light for him or her to become the live donor. So there is much more, and this is why the geneticists and nephrologists should collaborate and should share those patients and their families together as to provide the broad picture of the patients. The other thing that we should always remember before ordering genetic tests is that it is a burden, that it has side effects. And I'm not talking about side effects about dropping 5 milliliters of blood, because this is, of course, something unimportant. But there is a lot of burden on the very patient reflecting being suspected of genetic disease, of hereditary, of inborn, of something that is in his blood, and also what she will do with this information. So before ordering a genetic test, start talking to your patient, start consulting him, treating him as a partner, whether indeed he wants this genetic testing and whether he investigates any problems regarding this. We should deal with issues such as anxiety, fear, feeling of guilt, self-esteem, stigmatization, but also those patients, they have their own opinion on the family dynamics, whether I should have children since I have a genetic disease, whether there are particular reproductive issues. I already mentioned that the geneticist can help with pregnancies. I'm saying with prenatal, pre-implantation diagnostics, but to do so, we have to have the diagnostics. We have to know what is the underlying problem. So we need to have the patient, to consult the patient, to discuss with the patient those issues. Because otherwise, of course, patient will have his, her opinion on the subjects, which may be misleading, wrong, and definitely you as a clinical fellow, you should spend time discussing with the patient the aspects of being subject to genetic testing. So the things that you should discuss with the patient is, first of all, the scope of the test and its limitations. So what we are looking and what is the yield of mutation. It is not that all tests will give you the answer. Actually, we presume that in genetics, as of today, 40 to 60% of patients maximum can get the final diagnosis from genetic tests. We are still in progress of developing our tools, of developing the techniques, of discovering new genes. So sometimes there will be no clear answer, no clear benefit from this particular test that you will order today. And maybe this test needs to be repeated 2 or 3 years from now. We should also ask the patient whether he wants to hear about incidental secondary findings. And this is tricky because we don't know what we'll find. So we don't know, we cannot prepare the patient profoundly for the things that we are not ourselves sure that may happen. But some of the things you should already bear in mind. Sometimes we can find cancer risk mutations. Sometimes we can find mutations. For instance, myself, I'm dealing with WT1 patients. So those patients are at risk of disorders of sexual development. So, so this is an issue that we should discuss with them. Cancer, we can find diseases in this presymptomatic periods, and then ask the patient whether she wants to know that. Why wouldn't she want to know about what we have written in the genes? Oh, there's a lot of reasons for that. Even starting with something very close to the patient, like insurance issues, employment discrimination, some identity and privacy issues, also the question of who's my father, where the mutation comes from. A lot of things we can dig in our genes that maybe not always are what the patient wanted to hear from us. So please remember, spend your time on taking informed consent and for discussing opt-ins, opt-outs, pros and cons of having the genetic disease, genetic diagnosis. It's not CBC ordering. There is a law. If we have this genetic diagnosis, it changes the perspective of the patient for the rest of his life. And here I'm just showing you a link to National Human Genome Research Institute, where you can have a nice discussion on how to do it, how to do it. So there's some additional look up, read up for you when you can a little bit more practice preparing yourself for such a discussion with an anxious patient who really wants to know why he's sick, but also has to face the features related to this psychological burden of being genetically tested. So having done so, we finally can click, we can tick that we want to have the blood test taken and we want to have the test done. But which test? So let me move to the second part on my talk today, when I will present you some of the available tests that we have in genetics, and we'll discuss this with you which one can be offered. But before that, let me just present you the composition of human genome as a bookshelf. We have 46 books on this bookshelf called chromosomes. So we can say that the first thing that when we enter into library that is called John Doyle or Mary Smith, so every single patient has its own library composed of 46 books or 46 chromosomes. And then we can take any of those books to your hand. And of course, there will be a book describing your brain, a book describing your kidneys, describing your immune system, and so on. But it will not be that chromosome 1 is only for the neurological issues, or chromosome 2 is focusing on cardiology. All the different genes or all the different recipes are scattered throughout the different books. So I prefer to say that chromosome 1 is Mediterranean diet, and then chromosome 3 is Oriental diet, and there you have the recipes for different types of food or different types of genes used for building proteins in different organs. So you study your chromosomes, you check whether there are 46 or whether we have 46 books of the patient. The chapters are the regions, the chromosome 17p.1 or chromosome 2q13 are the regions notorious for mutations in certain genetic diseases. Then you start to take a single single book in your hand. You find pages, you start reading the right pages. There are 22,000 pages or 22,000 genes in all those 46 books or 46 chromosomes. So you understand there's a lot to read. And if you read those paragraphs, it's like reading a single gene, and then a single line represents an exon, so a part construction of the gene encoding your information, and then a single letter in a single book on a single page of a single chapter in a single book represent nucleotide, that its substitution can lead to a pathogenic effect. So you see, when ordering a genetic test, you have to decide whether you prefer to have the broad picture, so the picture of the library to check what are the chromosomes, whether there's everything in place regarding the recipes, or on the other hand, you can go into details, into peculiarities. So you take a single book, you check up the single page, and then find the single problem on a particular page. So the broad picture is a karyotyping or checking your chromosomes, a very classical method, one of the first discovered back in the 50s of the previous century. And on the second end of testing, so being very peculiar in details, we have sequencing. checking the sequence, checking letter by letter, nucleotide by nucleotide, the sequence of a particular gene. And here the classical one was the Sanger sequencing, when we're testing really manually, letter by letter, a particular gene. So just 1 or 2 pages were read. And now we have the more modern techniques called next generation sequencing, and much more robust, that allows us to read many pages at once. And so depending whether you want to have a broad picture or whether you want to go into details, you choose either cytogenetic broad picture or those letter reading parts. So the classical genetics or cytogenetics or karyotyping, checking whether you indeed have 46 chromosomes, is usually not performed in nephrology. Those tests are rather restricted right now. We use them for instance, in females who have primary amenorrhea, because we are thinking about Turner syndrome. Of course, when a patient presents a phenotype suggestive, for instance, for Down syndrome, because this is also something straightforward. But sometimes there would be need for genetic karyotyping in nephrology. It is when you have patient with ambiguous genitalia, or when you suspect patient to have disorder of sex development, because even to classify those patients or to address what subtype of problems with development of the gender they have, karyotype is necessary. And just remember that if we want to do karyotyping, you usually need to call your lab, check whether it's available there, and you need to take your blood sample on heparin. So there is a special tube that you need to have in those patients. Well, still today, we are doing cytogenetics in nephrology, but apart from problems with gender, with sex, and with ambiguous genitalia, usually we take a more precise, more detailed method called microarrays or array CGH that allows us not only to look on the chromosomes as shown on the left of this picture, but to look on those bars more precisely, and to identify a single gene deletion or few exon deletion. So we are using multiple microarrays. We can find out patients that have 1, 2, 3, 5 genes deleted, or 1, 2, 3, 4 pages missing from your library. Usually those patients present as patients having multiple congenital defects, intellectual disability, development delay, autism spectrum disorders, dysmorphic features. So they look like, we say, genetic. Yeah? They look genetic, and usually they are subjects to genetic testing by genetic departments, not by nephrologists. But there is a few notorious nephrotic kidney diseases that can be diagnosed with this technique. HNF1 beta deletion is a case in point, and nephronophthisis type 1 has a founder effect of deletion on chromosome, and then the cystinosis also has its own deletion. So sometimes you use this technique also to diagnose monogenic diseases, but either as the second tier or in combination with additional features. So what you should use in nephrology, in nephrogenetics, are the molecular tests. That should be either sequence checking by Sanger, old-fashioned, and I don't think many of you are using Sanger anymore, but those are rather next-generation sequencing, exome sequencing, or panel-based on exome sequencing that you just analyze in silico. And it's just the question of how much time and how much money you have. So many pages will be read by your collaboratory. So yes, those are the current standard techniques that we should start testing in our patients in majority of settings. So I said that Sanger sequencing is rather not used anymore because it's laborious, it requires manpower, and it just reads you 1 page, 1 paragraph, 1 sentence. So it's very narrow looking. But sometimes narrow, being very precise is a good thing. And that is when we have patients that have a very straightforward, clear phenotype, like WT1 disorders, then this Drash or Frazier syndrome, then you definitely know that you just need to test WT1 and you are done. So you don't need to spend more money. The second thing, when we use targeted sequencing, is in patients that already have a family member diagnosed. So then we know that on the page 2045 in line blah blah blah, in the letter there is a variant, there is a mutation. And then for the family members, we just check whether they have the variant in question or not. In family testing, we usually don't want to look broad because of all those issues that I reminded to you when discussing the informed consent aspects. So we don't want to know too much of the patient if he's just a symptomatic member of the family. We just want to know whether he inherited the familial variant that is responsible for the disease in this family. And the third thing that still you can find in the most of the textbooks is that we recommend Sanger sequencing in those populations when we have known founder mutations for specific genetic abnormalities like the Finnish type congenital nephrotic syndrome or some other examples. But actually, in the era of genome sequencing, this is not true. We cannot, when looking for the disease, we cannot be too narrow because we really need to know that we rule out presence of two factors at once. And let me give you two examples. As I'm mostly interested in hereditary glomerulopathies, when I started working in this field, we were just testing 2 or 3 genes because 20 years ago, it was nephrin and podocin who were discovered in European populations and were thought to be the reasons for hereditary proteinuria and hereditary genetic steroid-resistant nephrotic syndrome. But only over a decade later, it turned out that our Asian colleagues who could not find so many podocin-associated patients in their clinics, they cannot do so because they have completely different genetic background. And actually, in those Asian populations, CoQ8b or ADCK4, the previous name of the gene, is much more frequent. So what we know that looking back on the discovery timeline of hereditary steroid nephrotic syndrome, there are more and more genes emerging. And sometimes you have a patient that turned out negative on testing 10 years ago, but maybe he was coming from the wrong population, or maybe he was tested before a gene known for his diagnosis was discovered. So we need to go back to those patients and to re-diagnose them. We also realized that there were those classic proteinuria associated genes like nephrin and podocin, but then we, by having more and more patients presenting with and being diagnosed with genetic mutations, we learn out that there is a broader picture of patients presenting with symptoms. So some syndromic cases can be oligosyndromic. So syndromic, like syndromic Schinke, can present with proteinuria only, or on the patients with WT1 mutations don't have to have disorders of sexual development and the Williams tumor to have glomerulopathy. LAMP2 patients not always have eye problems, and so on, so on. So nowadays we know that in the past we are missing a lot of patients because we were just so narrow on genetic testing. So if you have a negative patient, you can go back to your genetic department and ask whether we can offer some broader picture, some broader testing for she, so to find the mutations that were in the meantime discovered. But even knowing that there is a known founder effect, like one of the things that we discovered in Central and Eastern Europe, that there is a notorious recurrent variant in collagen O5. even this, knowing that this is the leading diagnosis in our region, responsible for 40% of the families in Poland, for instance, we don't want our patients to be tested with only for this mutation, because since this mutation is so frequent in our region, it may happen that the patient has two mutations, that not only has this one, which is rather benign, benign in the course, and we may skip what is the second event present in the patient responsible for his more severe cause of the disease. So despite founder effects, we should screen patients with panels just to really have the broad picture and know whether this or that is the only reason for the problems that we observe in the kidneys. So just to summarize this part, NGS-based gene panels or exome sequencing-based gene panels are the current standard of testing, and this should be the test that you order. You just go to your department and you ask whether they have general nephrotic genetic kidney-related panel, or whether they divide it into tubulopathies, proteinuria, cystic diseases, but this is the tool that you should use. And this allows us to diagnose both oligosyndromic patients, those with atypical phenotypes. And really, I'm just showing you another publication that just came out last week. This is true even in adults. And this paper published last week in JASN from the New York group, they are showing that not only they had a high diagnostic yield in chronic kidney disease, but it also changed the management of their patients having this information at hand. Should we go as broad as exome sequencing? Maybe, maybe not. That I'm putting here that is a future gold standard. If we can afford it, that would be lovely. But of course, there are some limitations regarding the quality of analysis of those off-target regions. But again, a nice paper from Groupman et al. That proved that in patients, in adults, I'm not giving you the results for pediatric cohort, because in pediatrics the yields are even higher, but even in adults with chronic kidney disease, having genetic testing gives you the results in a substantial percent of patients. And also we can find some other actionable disorders that are unrelated to the nephropathy, but this also can be helpful in management of those patients. So exome sequencing would be the recommended standard for patients that have complex and very unspecific genetic disorder. And this is something that is happening right now in majority of European countries. That indeed we have either exome-based or exome sequencing performed in our patients, so we get at hand the information, the broad picture of the patient, what he has, when he has, and we also can look for candidate genes, but we can also look for additional risk modifiers and those are off target, like familial hypercholesterolemia that can additionally affect the level of cholesterol in our idiomatic patients. So just to bear in mind that yes, the times are changing, and all the classical techniques of genetics are a little bit behind what's happening right now, and sequencing based on next generation approach, including exome, is the golden standard. However, please remember that not always we can give you the genetic diagnosis. I started with this limitation. I told you that if you have those old patients diagnosed a few years ago, that you should go back to them. But even those that you will diagnose today, not always can have the diagnosis established yet. Having a negative a result of genetic test does not mean that it's not hereditary. And you have some, the reasons, it's very nicely discussed in this canonical paper from NDT from last year, when we discuss, depending on the type of the mutation and the type of the manifesting symptoms in the patient, what are the obstacles. So please remember that at the very end, the decision whether the patient is affected, whether the patient has the genetic diagnosis, is in your hands, in the hands of clinical doctor who deals with the patient. So your strong suspicion of genetic disease, your strong analysis, your the arguments from pedigree analysis can overrule a negative genetic result. And maybe 5 years from now we will be able to help you with this patient. But as of now, it is you who has the rights, who is right, not us providing you a negative result. With all this, I just want to I will be a little bit finishing in a moment, but my presentation was focusing on something called monogenic diseases. So when a single error in our DNA was causing symptoms, was responsible for all the symptoms present in the patient. But of course, you believe and you know it, that it's not always the true. That in majority of our patients, especially in adult patients, it is rather oligogenic or multifactorial. So of course, yes, we have a genetic predisposition. We have something in our genes, but there is a very substantial crosstalk with environment and with other features. And today, we can also measure these weaker factors. So factors who are not having high penetrance, so per se are not causative, but are rather considered risk factors. And for this, we are using so-called polygenic scores. So they can be genome-wide polygenic scores, or just you are just looking at multiple loci or multiple places, multiple pages on in different books of your genome, and trying to assess them jointly. So again, the broad picture is something that we really want to have. And this here is an example that you are trying to make a polygenic score of 10 different SNPs, so 10 different variations in our genome, and we are giving some power. So for instance, the SNP number 3, it's a stronger a risk factor for a given feature that we are analyzing. Some others are weaker, some other are protective, some other are risk factors. And then we run a test on the patient, and we give points for every single SNP that we analyze in the patient, and then estimate the combined risk. So with the polygenic score, we are not diagnosing your patient. We are not providing the diagnosis, because it is not a diagnostic test, it's a risk test. So it tells you whether your patient is at risk or whether your patient is eligible for the procedure, for this change that you want to do. And giving in view of the score you get from analyzing this multiple loci, you can divide your patients in those high risk or those low risk. And of course, those with high risk, they will be subject to some action that you want to propose, some intervention, while those on the bottom probability score are unlikely to have the need for the given intervention. And depending, I'm just showing you some examples of the polygenic risk scores for different diseases that were already published in a few years beforehand. We are also working on such polygenic scores in chronic kidney disease. But this just answers the question whether patient will benefit from intervention, whether the patient is at high risk of, for instance, requiring renal replacement therapy in the next 2 years or in the next 5 years, and so on, so on. Polygenic risk scores are not diagnostic. This is why, to summarize my talk of today, I would like to remind you that from the genes, we can read a lot of information about our phenotypic features. But what we don't see is the complexity of interaction between the genes and the environment. It's as shown here by these Lego blocks. I can take any piece of the Lego. I can check whether it's broken, whether it's correct, how much it weighs, how it looks like. But taking one piece does not give me the impression how it's organized, how it interacts with other elements of the puzzle. So still, this network of interaction is something that we need to learn, and let's hope that in the future that geneticists can be more precise in providing you final information. But to do so, of course, you need to run genetic tests and having the largest cohort of the patients diagnosed. We don't use polygenic scores in the setting of prediction of families risk, or in setting of embryo testing. There is in the recent years there was some publications, some riot, that some people were trying to use those risk scores to choose the better embryos, right embryos. But of course, this is statistics. It only tells you that maybe in the future something is more likely or less likely, but it is not diagnostic. So please remember, polygenic risk scores are not to select patients, are not to select embryos. Is just to stratify the risk and intervention in particular cohorts. And the last slides, and that's already invitation for the third part of the webinar that will be recorded sometime in the future. What do we do when we get the result of the genetic test? And I'm just reminding you that it's just the beginning. After diagnosing your patient with a genetic disease, you still have to go back to your patient to address all the psychological issues that I've mentioned. You should follow what is written in informed consent, so just reveal what the patient wanted to hear, not too much, not too little, and then deal with his family members, with his siblings, with future pregnancies. And all this can be done in collaboration with human geneticists. So just stay tuned in your departments, where are the geneticists, so they can help you handling the future of the patient who is diagnosed with a genetic disease. And just to remind you, there's also a lot of internet resources, a lot of web pages that can be used as the source information. And here I'm just showing you 4 of them, which are the most informative. There's of course our ERKNet webpage. There's Orphanet, the portal for rare diseases, and there are 2 American web pages. One is OMIM, Online Mendelian Inheritance in Men, which you can access through Medline. And the last but not least is the Gene Reviews book, which provides chapters on over 800 genetic diseases, giving you a very nice overview of most of the diseases that we are taking care of in daily life. So thank you very much for today. I will be welcoming any questions in a moment with Francesco, and please already stay tuned for the next webinars. Here is the schedule for the rest of the 2023 year. So thank you very much for listening, and let's have some discussion.
Thank you, Beata. You've been very clear. We have no questions for the moment, but please send in your questions. And I actually was expecting questions, so I didn't prepare any for you. You know, what I'm fascinated is actually in my practice, I've seen a few cases that were really puzzling, is this genetic scores that are used in some of our diseases, and the fact that people tend to take these scores diagnosis and not as risk factors. But on the other hand, when you have a sick child and he has the disease, then that genetic score sometimes makes the diagnosis. And it's often the case, for example, when you have atypical HUS, when you start having, a combination of unfavorable SNPs. I was wondering whether you could comment on that.
Yes, this is a lovely example. This is actually the exception to the rule when polygenic risk scores should be used in the clinic, in everyday clinic. And I mean, HUS, the complexity of this disease is a subject of a separate webinar and not even one. But indeed, this is an exception where when it's really handful for the clinics. But with my talk, I didn't want to go to the exceptions. I just wanted to present the broad picture on that and the rule, and especially what is happening now in on the internet when people want to choose to select embryos based on polygenic scores, which would be completely ridiculous because this leads us straightforward to eugenics and not to evidence-based medicine. So that was my point, but definitely for HUS, everybody who's listening, just go to the webinar and just learn that this is a beautiful exception.
I had to ask you a question. And, we have one. So let me just bring up the question. So Janina Elena Garcia Rodriguez is asking you, what do you recommend in patients with autosomal recessive mutations of rare diseases that could justify phenotype in patients with heterozygous? Do you want me to read it again?
Yes, no, I understand. So we have a disease that is that's supposed to be autosomal recessive, and then we run a genetic test and we find only one mutation or a heterozygote mutation. So we have, of course, two solutions for that. Because autosomal recessive diseases, by definition, with again a few exceptions, by definition, should have complete penetrance. So those patients who are carriers should not have symptoms of the disease. So one thing is that you miss the second mutation because it is in intronic, in deep intronic regions, in regulatory regions of the protein, was missed by the technique. And then you, as the leading doctor, just having one variant, already signed a paper that it is the diagnosis. And just to give you an example from completely different field, cystic fibrosis is a case in point. We believe that only 90% of patients with cystic fibrosis, when you just measure the chloride in your sweat, and you know that chlorides are high, and this is the only disease that causes high chlorides. 90% of the patients can be found to mutations. So if we would be judging those patients by genetic tests, 10% of patients would be missing the diagnosis. So then we have the clear functional test that confirms the diagnosis even in lack of second mutation. So that would be one case in autosomal recessive diseases. The second thing, which is less probable, apart from missing the diagnosis, is that sometimes in heterozygotes you can have a dominant effect of the variants, but then this family should follow dominant mode of inheritance. So that's a diverse, different story.
And can I add something? I think in these cases, some of the things which are, I think, very important is to prove that the mutation is de novo also. And I was wondering, how frequently do you do RNA-seq in these patients?
No, we don't do it on standard basis because of the problems with the tubes. You have, for an RNA-seq, you have to have special tubes in the clinic. So these are not covered by local insurance. So we just do it for research by purposes, unfortunately. So far, just please remember that if you want to RNA-seq, you should collaborate with some scientific center that has the proper tubes for that. Sometimes simple thing like taking the wrong sample already brings the bias to the test.
Because I've solved quite a few patients lately this way that had heterozygous mutations, and you sequence the RNA, you find that there is an exon skipping, and then there must be a hidden mutation somewhere in the intronic region. I found it increasingly useful. I mean, I've already done it 2 or 3 times this year.
Yeah, exactly. I mean, a very good example is Alport disease, if we are talking about kidneys. And there will be a webinar on it in next Saturday on missing intronic variants. Because again, in Alport, 90% of patients, like true, fully symptomatic patients, get the diagnosis. So we are looking for those missing variants, intronic variants with RNA-seq.
Wonderful. So I think we don't have any more questions, Beata. So why don't we just read together the next webinars. I think they're all very interesting. So William Morello will show us the results of the PREDICT trial, which was just published in the New England Journal of Medicine. And William is not from England, UK, he's from Milano, Italy. And then Arend Bokenkamp will actually talk to us about Lower syndrome. And then Jalila Mekali from Leuven, Belgium, will talk to us about ADPKD, and this will bring us to December of 23. So 3 very interesting webinars. Please join, and thank you for listening and learning together with Beata about genetic testing. Thank you.
Thank you very much, and have fun studying genetics in kidney diseases.
Yes. Okay. Good night.
Right.
Thank you. Bye.